The curtain closes. The laughter stops. An unexpected agonizing pain. A medical mystery unfolds, and a life devoted to bringing joy is tragically cut short.
In those critical moments, a misdiagnosis set in motion a chain of events that forever changed a family and ignited a worldwide mission to save lives.
Welcome to the Deep Dive, brought to you by Senior Forward Health. Today, we're embarking on an incredibly vital deep dive into the life and untimely death of beloved actor John Ritter. His story, while profoundly heartbreaking, serves as a powerful beacon, offering crucial health lessons, distinct warning signs, and critical medical facts that can impact all of us. As your guide, I'm eager to unpack this with you, and joining me is our expert, who has meticulously researched today's topic.
Glad to be here. It's an important one.
John Ritter's passing back in 2003 brought a relatively rare yet devastating condition into the spotlight. Can you start by setting the scene for us? What exactly happened on that tragic day?
Yeah, it's a somber story, but really crucial, especially for our listeners who, value understanding these complex health issues. So it was September 11th, 2003. And John Ritter, who, as you know, wasn't just this globally known actor from roles like, Jack Tripper in Three's Company.
A classic.
Absolutely. But he was also starring in his current sitcom, 8 Simple Rules. For Dating My Teenage Daughter.
Yeah.
He was actually on set doing what he loved, rehearsing lines.
Right.
And this was just 6 days before his 55th birthday.
Okay.
Just 6 days, which it really makes the suddenness of it all the more poignant,
Oh, absolutely. So close. He seemed to be at such a high point, still that same warm, funny guy.
Exactly. Still connecting with audiences. And then, suddenly things took a terrible turn.
I can almost picture him there making everyone laugh. And then what happened on set that day? What were the first signs?
Well, completely out of the blue, really. He started experiencing this whole cluster of severe, really alarming symptoms. He reported intense, just crushing chest pain, a profound tightness like he couldn't breathe properly, and along with that, nausea, vomiting, dizziness, shortness of breath. He was apparently drenched in this heavy, cold sweat.
That sounds terrifying.
It does. And according to some very vivid accounts, he actually verbalized this deep sense that something was very wrong. He even described it, I think the quote was, an internal disease in the ordinary instant.
Goodness. That phrase itself tells you how bad it must have felt.
It really does. It speaks volumes about the intensity, the internal distress he felt. So given how severe it was, he was rushed immediately to a nearby hospital. It was actually located right across the street from the studio in Burbank.
That's fortunate, at least geographically. So what happened when he got there? What was the immediate medical thinking?
Well, upon arrival, the medical team did what seemed honestly very logical at the time. They made an immediate diagnosis.
Yeah.
They believed he was having a heart attack.
Okay, that makes sense given the symptoms you described.
Exactly. The severe chest pain, nausea, sweating, dizziness, it closely mirrored acute myocardial infarction. That's, the blockage in the small arteries supplying the heart muscle.
Right.
So treatment for a heart attack started right away. Yeah. And that included recommending an angiogram, which is a standard procedure to look at the heart's blood vessels.
Okay. An angiogram. And I can only imagine the fear and confusion for his family, especially his wife, Amy Asbeck. She later talked about those hours, didn't she? Her testimony was quite powerful.
It was absolutely central, really, to understanding the emotional side, the human side, and the medical complexity of that day.
Yeah.
Amy Asbeck testified that she got the call, rushed to the hospital, and was told, yes, your husband is having a heart attack.
Just like that.
Just like that. And she recalled John actually expressing some hesitation, wanting maybe a second opinion about the angiogram.
Understandable, surely.
Completely. But according to her testimony, one of the doctors reportedly said, no, there's no time. You're in the middle of a heart attack.
Wow. That sense of urgency must have been immense.
Immense. Yeah. And it really highlights the pressure doctors are under with suspected heart attacks, where they believe every minute counts, life or death.
So, faced with that, what did she do? What did she say to him?
Well, she recounted leaning down to John, trying to be strong for him, offering comfort. She said something like, I know you're scared, but you have to be brave and do this because these guys know what they're doing.
Oh, heartbreaking. Trusting the experts in that moment.
Exactly. And then she mouthed, I love you, as they wheeled him away for the procedure.
Oh, gosh.
The real tragedy, the twist, came later. She was then told, just devastatingly, that his aorta was actually shredded.
Yeah.
And that the damage, the real underlying problem, was already done by the time he got there. And that's what led to his death.
So it wasn't the heart attack they initially thought.
No. That revelation that it wasn't a typical heart attack, but this other much rarer catastrophic event, it completely changed everything. It left this huge mark on his family, obviously, but also on the medical community.
It sounds like a truly terrifying and confusing situation, just an unimaginable ordeal. Now, you mentioned it wasn't a heart attack, but an aortic dissection. Can you clarify for us what exactly that is? Why is it such a critical emergency, especially if the symptoms can look so much like something else?
Yeah, and that's the truly insidious part, isn't it? The deceptive symptoms. It makes it a real master of disguise in the ER. So an aortic dissection is a profoundly serious condition. Basically, a tear occurs in the very inner layer of the aorta.
The aorta being the main artery from the heart.
Exactly. The main one. To really grasp how severe this is, don't just think of it as a tube. Picture it as the body's absolute main highway for blood. One source called it the Silver Nile of blood vessels, which I think is quite evocative.
The Silver Nile. Wow.
Yeah, it carries all the oxygenated blood directly from the heart to literally every single cell in your body. Its walls are incredibly strong, built for high pressure. They have 3 distinct layers: a smooth inner lining, a muscular middle layer, and a tough outer layer. Each one is crucial.
Okay, so 3 layers making up this vital highway. If there's a tear in that inner layer, how does that cause such a catastrophe? What happens to the blood flow?
Right, well, the mechanism is just as destructive as it is fast. When that inner layer rips, blood, instead of flowing smoothly down the main channel, suddenly gets forced through that tear.
Oh dear.
It then starts tunneling its way between the inner and middle layers of the aortic wall. It literally splits them apart, dissects them. That's where the name comes from.
It creates a new path.
Exactly. It creates what we call a false lumen. Basically, a new unauthorized pocket or channel within the aortic wall itself. Think of a river suddenly diverting underground, taking a huge chunk of the main flow with it.
So the main path is compromised.
Severely. Its ability to deliver life-sustaining oxygen and nutrients is drastically reduced.
That sounds incredibly dangerous. What are the immediate consequences? What happens to the body?
Well, the consequences are immediate and often devastatingly severe. Because so much blood, oxygen, and nutrients are now going down this wrong path, this false lumen, they can't reach the vital organs they're supposed to supply.
Like the brain, the heart itself.
Precisely. The heart, the brain, lungs, kidneys, even your arms and legs. And as more blood gets trapped in this false channel, the tear itself can get bigger, fast, making the problem worse exponentially.
So it's a downward spiral.
A rapid one. It can lead to a whole cascade of severe complications. A stroke if the brain's blood supply is cut off. Damage to the heart valves if the dissection reaches the point where the aorta leaves the heart. Or, the most deadly outcome, the tear can go all the way through all 3 layers. That's called an aortic rupture, massive internal bleeding.
And that's usually fatal.
Almost always, and almost instantly. It's a stark reality, but a staggering 0% of people who have an aortic dissection die before they even reach the hospital.
40%. That's unbelievable. It just hammers home how urgent this is.
Absolutely. The speed is terrifying.
That statistic is truly sobering. Are all dissections the same, or are there different types? Does that affect the treatment?
That's a really important distinction, yes. Classifying them helps guide the emergency response. We mainly talk about 2 types, type A and type B.
Okay.
Type A dissections are more common, and critically, they're far more dangerous. This type involves the upper part of the aorta, the ascending aorta. That's the section closest to the heart, where all the major arteries branch off to your head and arms.
Right near the source.
Exactly. The tear might also extend downwards into the descending aorta, towards the abdomen. Because it's so close to the heart and those crucial branches, type A almost always requires immediate open chest surgery, often within hours.
Okay, immediate surgery for type A. What about type B?
Type B involves only the lower part, the descending aorta, and it might extend into the abdomen as well. While still very serious, type B doesn't always need immediate surgery. Sometimes it can be managed with aggressive medication, really focusing on controlling blood pressure and heart rate, trying to reduce the stress on the aortic wall and stop the tear from getting worse. But close monitoring is always essential.
So it's a rare condition overall, but incredibly dangerous and incredibly fast when it happens.
Precisely. It only affects, maybe 5 to 10 people out of every 100,000 each year.
Yeah.
But it's responsible for this alarmingly high number of tragically avoidable deaths.
Yeah.
And that high death rate comes down to that rapid onset, those deceptive symptoms that look like a heart attack, and just how critical time is for diagnosis and treatment.
You've painted a very clear, if quite sobering picture. The speed, the severity, the mimicry, all makes it so dangerous. But if it's so dangerous, why is it still such a challenge for doctors to diagnose it quickly, especially when, as you said, every minute counts, like in John Ritter's case?
This really gets to the heart of the diagnostic challenge, doesn't it?
Yeah.
And it's something critical for everyone, especially our listeners, to grasp. John Ritter's case is such a stark example of this dilemma that emergency doctors face, well, daily. His symptoms, that intense chest pain, the nausea, the sweating, they so closely mimic a heart attack. It's an incredibly common and dangerous overlap.
Right.
And it's not just heart attacks. Aortic dissection can also cunningly look like other serious things, like a pulmonary embolism, a blood clot in the lungs.
So the doctors are juggling possibilities.
Exactly. Imagine the pressure. They have minutes sometimes to accurately tell the difference between several life-threatening conditions, and each one needs a completely different immediate treatment. Get it wrong, and the consequences can be dire.
It sounds like walking an almost impossible tightrope in the ER.
It absolutely is. Think about it. Identifying and treating a severe heart attack, what we call a STEMI, fast is critical. Delays mean irreversible heart damage, or worse.
Right, you have to act fast for a heart attack.
But here's the cruel irony. If you misdiagnose a heart attack when the patient is actually having an aortic dissection, you fatally delay the correct life-saving treatment, which is usually urgent surgery for the dissection.
A devastating mistake.
Devastating. In John Ritter's case, he had that dangerous type A dissection in the upper aorta right near the coronary arteries. His underlying aortic aneurysm, the bulge, was actually discovered during an aortogram. That's a specific test where they inject dye into the aorta to see it clearly. And it's often done as part of a coronary angiogram when they suspect a heart attack. So the diagnosis came about somewhat unexpectedly during the heart attack workup.
And as you mentioned, with this condition, every single minute matters.
It cannot be overstated. We know very clearly that the death rate for aortic dissection goes up by 1% for every single hour that the diagnosis and the surgery are delayed. 1% per hour.
That's terrifying.
It is. And it puts this immense, almost unbearable pressure on medical teams and emergencies to make the right call right away.
And this led to legal action afterwards, didn't it?
Yes, it did. After his death, Amy Yazbek and the family filed wrongful death lawsuits. They argued there was negligence due to the misdiagnosis and the delay in care. They did secure some previous settlements against the hospital and several other medical personnel, totaling around $14 million.
Okay.
However, in a separate, much larger lawsuit for $67 million, the two specific doctors who treated him that day were later cleared, found not negligent.
So a complex legal outcome.
Very complex, and it really highlights the inherent difficulties in these cases, the challenges of proof, and how care can be interpreted differently by the legal system versus perhaps the medical community reflecting internally.
That legal side really underscores the difficulty of making these split-second diagnoses. I understand his passing also triggered a lot of discussion within the medical world itself about protocols and diagnosis.
You're absolutely right. It sparked significant debate. And what's interesting is seeing how emergency medicine providers processed it. You could see discussions even on forums like Reddit, where doctors were really digging into the diagnostic choices. Should they have done a chest x-ray, a XSR right away?
Yeah.
Or maybe a CT angiogram, a CTA.
What was the consensus?
Well, many experts pointed out that a chest x-ray probably would have looked normal in his case. He was relatively young, 54, and that classic sign of a widened mediastinum. The space around the heart looking bigger on x-ray isn't always there, especially early on.
Okay, so a chest x-ray might not have helped. What about the CT scan?
The CTA is the definitive test, yes. But performing CTAs on every single person who comes in with chest pain suggesting a heart attack would cause huge problems.
Why is that?
It would massively delay treatment for the vast majority who are actually having a heart attack, and for them, time is muscle, time is life. Plus, you're exposing many people to unnecessary radiation.
Right, it's a balancing act.
It is. The strong feeling was that it's just incredibly difficult to catch these atypical cases. And the key takeaway for clinicians was the need for a really high index of suspicion, especially if a patient's symptoms aren't responding to standard heart attack treatment, or if their pain is unusually severe or has that specific tearing quality.
So it comes down to clinical judgment and suspicion.
A lot of it does, yes. It's a reminder that medicine isn't always black and white. It's often about subtle clues, pattern recognition, and that crucial index of suspicion.
It's clear the stakes are incredibly high for everyone involved, patients, families, doctors. John Ritter's tragic death, while such a personal loss, really has become a catalyst for change, hasn't it, in how aortic dissections are approached worldwide. So what positive things have come out of this tragedy to help prevent others from going through the same thing?
This is where we see John Ritter's most enduring and perhaps most impactful legacy. It's quite remarkable, actually. Just weeks after his death, his wife, Amy Yazbek, channeled her grief into something incredibly proactive. She established the John Ritter Foundation for Aortic Health.
Wow, so quickly.
Yes. Its urgent purpose right from the start was to prevent the kind of unnecessary suffering her family experienced. They focus on dedicated research, widespread education, and strong advocacy. The goal is really fundamental: to change the conversation, to make aortic health a routine part of discussions between patients and doctors, making sure awareness is dramatically increased everywhere.
That's an amazing tribute, such resolve. And I believe the foundation created a set of specific guidelines, the Ritter rules, to help people recognize the signs. Can you walk us through some of those? Why are they so crucial for our listeners to know?
Absolutely. The Ritter rules are fantastic. They're a set of 10 really important guidelines carefully put together to empower both the public and medical professionals. They give you the knowledge needed to recognize, diagnose, and ultimately prevent aortic dissections. These are truly life-saving pieces of information designed to make a complex emergency understandable and actionable.
Okay, let's hear them.
Right. The first rule hammers home urgency. Thoracic aortic dissection isn't just serious, it's a profound medical emergency. Remember that chilling statistic. The death rate climbs 1% every single hour. Diagnosis and surgery are delayed.
1% per hour. Got it. Act fast.
Exactly. Time isn't just money, it's life. If you suspect it, immediate action is critical. The second rule focuses on pain. Severe pain is the the most defining symptom. This isn't a minor ache. It's often a sudden, intense onset of severe pain. Could be in the chest, stomach, back, or neck.
And the type of pain is specific.
Very often, yes. People describe it as sharp, tearing, ripping, or sometimes even moving from one place to another. And maybe most tellingly, many patients report this overwhelming gut feeling that something is very, very wrong. That feeling should never, ever be dismissed.
That internal alarm bell. So not just any pain. What about the misdiagnosis issue we talked about, the heart attack confusion?
That leads straight to the third incredibly vital rule: misdiagnosis. Aortic dissection can tragically mimic a heart attack. Heart attacks are much more common, so they're often the first thought. But, and this is key, if a heart attack or some other diagnosis isn't clearly and quickly confirmed, aortic dissection must be considered and ruled out quickly.
Especially if there are risk factors.
Exactly. This is particularly important for you if you have a family history of thoracic aortic aneurysm or dissection, or if you have features of one of those genetic syndromes we'll talk about. Don't hesitate to ask your doctors, could it be aortic dissection? Have you considered it? Especially if the heart attack picture isn't quite fitting.
Okay, be proactive. Ask the question, what about confirming the diagnosis? What tests are needed?
That's rule number 4, imaging. Getting the right scan is absolutely paramount. This is critical for you to know. Only 3 specific types of imaging studies can definitively identify aortic aneurysms and dissections. Those are CT, which is computed tomography, MRI, magnetic resonance imaging, and a T, or transesophageal echocardiogram, which is an ultrasound probe down the esophagus.
Okay, CT, MRI, or TEE, what can't rule it out?
This is the crucial takeaway.
Yeah.
A standard chest x-ray or an EKG, electrocardiogram, cannot rule out aortic dissection. They're useful for other things, but not this. Knowing the distinction could genuinely save your life or someone else's.
That's vital information many people probably don't know. Okay, so those rules covered the emergency situation. What about identifying risks before something acute happens?
Exactly. The next set of rules shifts focus from the crisis to proactive prevention and risk awareness. Rule 5 identifies a key risk factor: aneurysm. Aortic dissections often happen because there was already an enlargement, a bulge, in the first part of the aorta. That bulge is called an aortic aneurysm.
Like a weak spot.
Precisely. Think of it as a weakened, bulging spot in that silver Nile. Having an aneurysm significantly increases your risk for a dissection. So if you're diagnosed with one, careful, regular monitoring is absolutely essential.
Okay, monitoring aneurysms. What else?
Rule 6 highlights another major risk factor: history. A personal or family history of thoracic aortic disease puts you at much higher risk. If you or a close family member live with an aneurysm or have had a dissection, it is critical that other first-degree relatives, parents, siblings, children get evaluated. These conditions definitely can run in families, often silently.
So genetics play a big role.
A huge role, which leads to Rule 7, risk factor. Genetic syndromes. Certain specific genetic syndromes that affect the body's connective tissue greatly increase the risk. We're talking about conditions like Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome, and Turner syndrome.
These weaken the aorta structure.
Exactly. They weaken the very tissues that give the aorta its strength. If you or a family member have any of these syndromes, regular aortic screening isn't just recommended, it's absolutely vital.
Okay. Any other specific structural things to know about?
Yes, Rule 8 covers another structural risk factor, bicuspid aortic valve. If you have a bicuspid aortic valve, meaning you were born with only 2 leaflets in your aortic valve instead of the usual 3, or if you've had surgery to replace one, you need ongoing monitoring for thoracic aortic disease. It's a common congenital heart defect, and it significantly increases aortic vulnerability over time.
So being aware of inherited risks and structural heart issues is key. What about things we do, lifestyle choices or external events? Can they trigger a dissection?
Yes, absolutely. Rule 9 deals directly with triggers. Certain lifestyle choices and also physical trauma can definitely trigger an aortic aneurysm or dissection. This includes direct injury to the chest, like in a car accident. Also, extreme physical training, think very heavy bodybuilding or intense resistance training, especially if done improperly with breath holding.
Okay. What about substances?
Illicit drug abuse is a major one, particularly stimulants like methamphetamine or cocaine. They cause huge, sudden spikes in blood pressure, putting immense stress on the aorta. Also, poorly controlled high blood pressure itself is a trigger, as is suddenly stopping necessary blood pressure medications. Don't do that without talking to your doctor.
That makes sense. Anything else?
More rarely, pregnancy can be a trigger, especially in women who already have an aortic aneurysm or one of those connective tissue disorders. It requires careful monitoring during pregnancy and postpartum.
Right. So we've covered urgency, pain, misdiagnosis, imaging, risk factors, and triggers. What's the final rule?
The 10th rule wraps it all up with prevention. Proactive medical management is essential. If you know you have thoracic aortic disease, then optimal blood pressure control is paramount. Regular aortic imaging to watch its size and condition and often genetic counseling are strongly recommended. This comprehensive, proactive approach, guided by your doctor and likely a team of specialists, is your absolute best defense.
These Ritter rules are incredibly comprehensive. They really do feel like a lasting legacy, turning such a tragedy into tangible, life-saving knowledge for all of us.
They really are.
It sounds like understanding those risk factors is just paramount. Can you elaborate a bit more on the primary causes and risk factors our listeners should really be tuned into for themselves or their loved ones?
Definitely, because moving from awareness to prevention means digging into these causes and risks. And while they're diverse, some really stand out. High blood pressure, hypertension is by far the most common and the single most significant risk factor. Think about this statistic. More than 2/3 of people who have an aortic dissection had pre-existing high blood pressure.
2/3? That's huge.
It's huge. It tells you where a lot of the focus needs to be. Chronic high blood pressure, just relentless pounds away at the aorta's walls. Over time, this causes them to thin, stiffen, weaken, deteriorate, making them much more likely to tear suddenly.
So managing blood pressure is job number 1, really.
If you track just one thing for aortic health, blood pressure is arguably the most critical for the general population.
What are some of the common things that contribute to high blood pressure that people should be mindful of in their daily lives?
Well, there are several well-known contributors, things you can often modify. Being overweight or obese is a major one. A lack of regular physical exercise, consistently eating a diet high in salt, not getting enough fruits and vegetables.
Lifestyle factor.
Big lifestyle factors. Then there are habits. Smoking is terrible for blood vessels. Excessive alcohol intake. And particularly, as we mentioned with the triggers, using stimulants or illicit drugs like meth or cocaine, these can cause drastic, immediate spikes in blood pressure. And while regular moderate exercise is fantastic, it's worth noting again that very high-intensity activities, like maximal weightlifting, can cause temporary but very high blood pressure surges during the activity. This could be risky if you have an underlying vulnerability you don't know about.
What about stress? Does that play a role?
It can, yes. Chronic stress keeps releasing stress hormones, which can increase heart rate, narrow blood vessels, and contribute to elevated blood pressure over time.
And genetics. Does high blood pressure run in families too?
Yes, there's definitely a genetic component to hypertension risk. And when you combine that genetic predisposition with shared family habits, maybe unhealthy diets or lack of exercise within a family, the risk could be significantly compounded.
It seems like genetics are a recurring theme here, even beyond just blood pressure.
Absolutely. Identifying these genetic links is incredibly important because many dissections are rooted in these underlying conditions. We use the term heritable thoracic aortic disease, HTAD. That covers forms where the only sign might be the aneurysm or dissection risk itself, nothing obvious externally.
So you wouldn't even know.
You might not. Then there are the specific connective tissue disorders many people have heard of. Marfan syndrome, Loeys-Dietz syndrome, vascular Ehlers-Danlos syndrome. All of these fundamentally weaken the connective tissues, the glue that holds the aorta together, making it prone to stretching and tearing.
Okay. Any other genetic conditions?
Yes. Things like Turner syndrome, which affects females, can also lead to heart defects and high blood pressure, increasing aortic risk.
And what about heart structure issues people might be born with?
That's another crucial category, congenital heart defects, problems present from birth. The most common one linked to aortic dissection is that bicuspid aortic valve. We mentioned 2 leaflets instead of 3.
Right.
That causes abnormal blood flow patterns and stress on the aorta over a lifetime. Another one is coarctation of the aorta, which is a narrowing of the aorta itself. Both put extra strain on the aortic wall right from the start.
So how common is this genetic link overall?
It's estimated that around 20%, 1 in 5 people who have an aortic dissection have a clear genetic predisposition.
1 in 5.
Which makes knowing your family medical history not just helpful, but potentially life-saving information to share with your doctor.
Definitely. Are there any other factors listeners should consider when assessing their own risk profile?
Yes, a few others. Having a pre-existing aortic aneurysm, that bulge we discussed, is a major risk factor for dissection. It's already weakened. Atherosclerosis, hardening of the arteries due to cholesterol buildup, can contribute, as can inflammatory conditions like giant cell arteritis, which affects large arteries. And, as mentioned in triggers, significant chest trauma or injury can sometimes lead to a tear later on.
You mentioned demographics earlier.
Yeah.
Men more likely, certain age groups.
Yes, men are about 3 times more likely than women, though women often have worse outcomes if it happens. The peak age is generally 40 to 70, making up about 3/4 of cases. And individuals of Black African or Black Caribbean descent seem to have a higher risk.
But can affect anyone.
Crucially, yes, anyone, all ages, races, sexes. Vigilance is key for everyone.
Now, there was that anecdotal mention in the sources about potential past drug use regarding John Ritter. How should we approach that sensitive information in this medical context?
Right. That's important to address carefully and impartially. We need to focus on the established medical facts, not unverified personal stories from decades ago. One source did mention someone claiming to have seen John Ritter use cocaine back in the late 70s. We cannot verify that specific anecdote. However, the broader medical point, which is strongly supported by research and is included in the Ritter rules, is absolutely valid. Illicit drug abuse, especially stimulants like meth and cocaine, is a significant trigger and risk factor for aortic dissection.
Because of the blood pressure spike.
Exactly. These drugs cause immediate dramatic surges in blood pressure and heart rate. This puts immense sudden stress on the cardiovascular system. It can absolutely initiate a tear in a weakened aorta or contribute to aortic disease developing over time.
So the medical link is clear.
The medical link is clear and important, and it underscores why it's so vital for you to have open, honest conversations with your physician about all potential lifestyle factors, including any past or present substance use. It's not about judgment. It's about understanding your full health picture to ensure proper prevention and care. These things can have serious, sometimes hidden implications for your heart health.
That's a very clear explanation, focusing on the medical relevance. So, summing this section up, what does this all mean practically for prevention and monitoring for our listeners? How can they be proactive?
The biggest takeaway here is that early detection isn't just good. It's absolutely paramount for survival. Routine tests to monitor aortic health are crucial if you have known risk factors like family history, high blood pressure, one of those genetic conditions, or if any suspicious symptoms pop up.
What kind of tests?
Usually echocardiograms or CT/MRI scans, depending on the situation and risk level. Genetic counseling and testing can also be incredibly helpful, both for individuals and their family members, to identify any underlying predispositions before a crisis.
knowledge is power.
Absolutely. Knowing your risk allows for proactive screening, careful monitoring, and early management strategies like strict blood pressure control. Ideally, especially for those with known risks, care involves a team. A cardiologist, a cardiovascular surgeon, maybe a medical geneticist, all working together to manage the condition and prevent a dissection from ever happening. It's about building that protective shield of awareness and proactive medical care.
This is incredibly important information. That role of family history and genetics really stands out. And it brings us directly to another incredibly powerful and cautionary story from John Ritter's own family, doesn't it? Can you tell us about his brother, Tom Ritter? What did his experience reveal about these critical genetic links?
Yes, Tom Ritter's story is profoundly moving. It really shows how John's personal tragedy became this life-saving wake-up call for his own brother, powerfully illustrating the importance of knowing your family history. Tom was John's older brother, and they shared an extraordinarily close bond their whole lives. John was known to be very protective of Tom, who was born with cerebral palsy, which perhaps deepened their connection.
So they were very close.
Very close. And tragically, it turned out their lives were intertwined not just emotionally, but also through this shared genetic predisposition to aortic disease.
So after John died so suddenly from this, did Tom immediately think, I might be at risk too?
Not instantly, perhaps, but the awareness within the family grew significantly after John's passing. It was actually 4 years later, in 2007. Family members, now acutely aware of the potential for genetic heart issues because of what happened to John, really urged Tom to get an aortic scan.
They pushed him to get checked.
They did. And that proactive step, born out of grief, but also this newfound knowledge, proved to be incredibly foresightful. It was a decision that literally saved his life.
What did the scan show? Was it serious?
The results weren't just alarming, they were described as chillingly similar to John's condition at the time of his death. Tom's aorta was found to be dangerously enlarged, dilated. In Tom's own words, it was on the verge of a potentially fatal rupture.
Wow. Just like John.
Eerie similar was the description used. Tom called it a profound wake-up call. He realized he'd been living completely unaware as a ticking time bomb. The invisible threat suddenly became terrifyingly real for him.
That must have been absolutely terrifying to hear. But also, in a way, an incredible second chance, right? A direct result of his brother's legacy.
An incredible second chance, absolutely. A true gift in a tragic way. Within just days of that diagnosis, Tom underwent emergency surgery to repair his weakened aorta.
That quickly?
Yes. The procedure was complex, it carried risks, but ultimately it was successful. It gave him, as he said, a chance that John never had. A chance to intervene before the catastrophe.
That's amazing.
Tom's survival just powerfully highlighted the genetic component of these aortic issues and the critical life or death importance of family screening, of knowing your medical history deep down. His experience really underscored in the most personal way how John's death, while tragic, had indirectly but profoundly saved his own brother's life. It turned that loss into this critical, life-saving lesson.
Tom's story is such a powerful testament. It really drives home how crucial these genetic links are and the impact of the Foundation's work in raising awareness. Did this lead to more focused research on the genetics?
Absolutely. And this is where John Ritter's legacy truly blossoms into widespread hope and action. Tom's experience, combined with the Foundation's unwavering mission, led directly to establishing the John Ritter Research Program, the JRRP. This program started in 2010 with crucial funding and support from the John Ritter Foundation. It's based at the University of Texas Health Science Center in Houston, led by a renowned expert, Dr. Deanna Melovich.
What's its main goal?
The JRRP is laser-focused on discovering more genes that cause thoracic aortic aneurysms and dissections. They want to better understand how genetics and environment interacts to create risk, and they collect detailed data on symptoms associated with these conditions.
Gathering more knowledge.
Exactly. By 2023, they had enrolled over 1,500 families in this groundbreaking research. Families united by this condition, all contributing to improved clinical care and quality of life for everyone affected down the line. And naming the program after John Ritter helps significantly. It brings a spotlight to the research, and it makes patients and families feel more comfortable participating, creating this community built on shared experience and hope.
It sounds like the Foundation is making huge strides, both in that cutting-edge research and in getting the word out.
They really are. Their efforts are so commendable and wide-ranging. The Foundation has greatly expanded its virtual library called Aorta Academy. This makes sure the latest recommendations, clinical guidelines, vital knowledge are easily accessible to doctors and the public. democratizing information.
Making it available to everyone.
Yes. And beyond the research and online stuff, they actively share impactful patient and family stories. They share these with clinicians at medical conferences, at aortic clinics across the country. It brings that vital human element into medical education and advocacy. It reminds everyone what's at stake. These comprehensive efforts truly embody John Ritter's enduring legacy, transforming personal tragedy into a global movement for aortic health and awareness.
Tom's story really is a testament to the power of that awareness and proactive screening. It underscores that while we can't always control everything about our health, we can be vigilant, can't we?
We absolutely can.
As we bring this deep dive to a close, what final thoughts or perhaps hopeful messages do you have for our listeners based on everything we've discussed?
Well, what truly stands out, I think, amidst the tragedy, is the immense and growing hope that has emerged. John Ritter's passing was undeniably a profound, devastating loss. But his legacy, amplified through the incredible work of the John Ritter Foundation and those clear, actionable Ritter rules, has genuinely saved countless lives. It's done that by dramatically increasing awareness.
Knowledge is power.
Knowledge is absolutely the most potent power we possess in preventing future suffering from aortic dissection. It really comes down to being informed. Understanding your individual risks, paying close attention to family history, any genetic predispositions, and maybe most crucially, learning to really listen to your body, especially when it gives you that powerful, undeniable gut feeling that something is very wrong.
Trusting that instinct.
Trusting that instinct. And importantly, feeling empowered to advocate for yourself and your family within the medical system. Don't be afraid to ask questions. Don't hesitate. If anything we've talked about today resonates with your health history or your family's history, or maybe symptoms you're experiencing now, please do not delay. Talk to your physician. Get it checked out. Early detection, proactive management, using the right diagnostic tools when needed. These are your absolute best defenses against this silent, swift, and potentially devastating condition. There is hope, and it lies in awareness and action.
Today, we've taken a deep dive into the life and death of John Ritter and the profound medical lessons that emerged from his story. We've learned about the critical urgency of aortic dissection, the subtle but severe symptoms, and the crucial Ritter rules for early detection and prevention. We've also highlighted the immense importance of knowing your family's medical history, powerfully shown by Tom Ritter's life-saving experience, and the vital, ongoing work of the John Ritter Foundation. This truly is knowledge that can save lives. As we close our deep dive today, maybe consider this. What silent family histories might be waiting to be uncovered in your own life, holding the key to preventing a similar tragedy? Thank you for this invaluable and deeply insightful conversation.
Thank you for having me. It's crucial information to share.
And thank you, our listeners, for joining us on the deep dive. For more vital health insights, make sure to subscribe to Senior Forward Health.